Hi guys, today we're going to dive into one of the most important foundations of safe and effective medication use, pharmacokinetics and pharmacodynamics, which essentially looks at how drugs move and how they work. If you've ever wondered why the same drug affects people differently, or why we adjust doses in renal failure, the elderly, or liver disease, then this video is for you. We're going to break it down simply and clinically, and then we're going to look at some specific clinical cases. So we'll start with pharmacokinetics, which looks at how the drugs moves around the body. And the first component of that is absorption. Absorption looks at how the body gets into the bloodstream. And the first thing that influences this is the route of administration. There are many different ways to administer medications, and the chosen route is going to impact your absorption. For example, oral drugs need to survive the GI tract, so they have to get through acid and enzymes. Intravenous will be 100% absorbed pretty much immediately. Intramuscular or subcut will depend on blood flow to the tissue in the area, and then sublingual actually avoids the liver entirely. And this leads us to bioavailability, which is the percentage of the drug that actually reaches systemic circulation. So IV would be 100%, but with oral drugs it varies widely, and it's much harder to control or predict the bioavailability of an oral drug. What if the patient has an ileus, for example? And then first pass metabolism. Oral medications travel via the portal circulation to the liver, where a significant portion may be metabolized before reaching the rest of the body. This is why some drugs require bigger oral doses or are just not given orally at all. Once the drug is absorbed, it needs to distribute around the body. So we move to distribution. Many drugs bind to albumin in the bloodstream, which is a type of protein, and only the unbound or the free drug is actually active. So in patients with low albumin states, such as malnutrition, liver cirrhosis, or the elderly, there'll be more free drug and higher risk of toxicity. Volume of distribution tells us how widely a drug spreads into tissues versus staying in the bloodstream. So a high volume of distribution, or VD, means that the drug goes deep into the tissues, whereas a low VD means that the drug stays mostly in plasma. Now, the blood-brain barrier is an important concept to understand also because only certain drugs can cross, particularly small lipid-soluble molecules, and others stay out, which is important for central nervous system effects and side effects. It needs to be taken into consideration where you're treating something neurological as well as when you don't want side effects in the CNS. A good example would be someone with meningitis who requires antibiotics to treat the CNS. Metabolism mostly happens in the liver and involves enzymatic breakdown, usually through the CYP450 system. But this will be a whole other video because CYP450 is quite complicated. Drugs can either be enzyme inducers, which speed up metabolism, so something like rifampicin, or enzyme inhibitors, which slow it down. Examples would be amiodarone or macrolides. And we also revisit first pass metabolism when we look at metabolism because oral drugs can be metabolized extensively before even reaching systemic circulation. Additionally, some drugs have active metabolites, whereby the breakdown products are still pharmacologically active. So things like codeine, which convert to morphine. And this affects drug duration and toxicity. And also what happens in terms of the active component of the drug and the pharmacodynamics of the drug, which we look at shortly. The final stage in pharmacokinetics is excretion. So most drugs leave the body through the kidneys, some through bile, and a few through the lungs or sweat. And renal excretion depends on glomerular filtration rate, or GFR. So it's highly relevant to look at in renal impairment because drug accumulation equates to toxicity. You also need to consider dialysis. So if a patient is on hemodialysis, some drugs will be dialyzed out and others aren't. And this impacts dosing regimes and timing. For example, if a hemodialysis patient is charted amoxicillin, which is effectively removed by dialysis, they will require repeat dosing after their dialysis session. Biliary excretion, so that's where fat-soluble drugs may be excreted in the bile and reabsorbed in the gut. And finally, half-life. So this is the time it takes for plasma concentration to fall by 50%, and it determines dose frequency, because longer half-life equals fewer doses, but longer time to steady state or wash out. So next we look at pharmacodynamics. So we're moving away from how the drugs move to how they work. And pharmacodynamics essentially looks at the mechanism of action of the drug. And in general, drugs work by binding to receptors. And receptors are proteins, usually on the cell membrane or inside the cell, that respond to chemical signals. Think of them a bit like communication points or switches that turn processes on or off and targets that the medications act on. Examples would include beta receptors on cardiac cells, opioid receptors in the CNS, or histamine receptors in smooth muscle. And the receptor is sort of like a lock, and the drug is the key. And only certain keys will fit certain locks. Either the key fits and opens the lock, meaning it's an agonist, or it fits the lock but doesn't open it. blocking another key from using it, an antagonist, or it can partially activate or partially block. So agonists activate a receptor, and examples would be adrenaline in anaphylaxis, and antagonists block a receptor. So examples might be beta blockers or naloxone in opioid overdose, where the naloxone will actually push the opioids off the opioid receptors. So the next component of pharmacodynamics is the drug dose response relationship. And there are really two key terms to remember here. The first being efficacy, which is the maximum effect that a drug can produce, and the second being potency, which is how much drug is actually needed to produce an effect. So essentially, the dose response curve shows how a drug's effect changes as the dose increases. So think of it like this. If you have a small dose, there's a small effect. As you increase the dose, you have an increasing effect. But at some point, eventually the effect will plateau because all of the receptors are occupied or the system's maxed out. So it looks a bit like a sigmoid S-shaped curve on a graph, which you can see on the screen now. EC50 refers to the concentration of drug that's required to reach 50% of the drug's maximal effect. And the lower the EC50 is, the more potent the drug. So you can think of EC50 as how much do I need before this drug reliably works halfway? And to make it more clinical for you, we'll consider a specific drug. So for example, two different drugs that raise blood pressure. Drug A reaches 50% of its maximum blood pressure effect at 2 milligrams, whereas drug B reaches the same at 10 milligrams. So drug A has a lower EC50, which means that it's more potent. But if drug B's maximum possible blood pressure increase is greater, then drug B will have the higher efficacy. So efficacy is the ceiling of effect, whereas EC50 is the potency. So next we're going to talk about the therapeutic window or the therapeutic range. And the therapeutic window is essentially the safe range between the minimum effective concentration and the toxic concentration. So drugs with a narrow therapeutic index, like digoxin, lithium, or phenytoin, need careful dosing and monitoring to avoid toxicity or subtherapeutic dosing. So if you think about it like a safe zone, below the window is subtherapeutic. The drug's not going to work and the patient gets no benefit. Inside the window, you get the optimal effect with minimal adverse effects. And then above the window, the drug becomes toxic, and that's where harmful or dangerous effects occur. And some drugs will have a wide therapeutic window, which means they're very forgiving and easier to dose, whereas some have a narrow or therapeutic window where it's very easy to under or overdose. So if we look at digoxin as an example, dig is a classic narrow therapeutic window. And the window is narrow because it has a long half-life, it's renally cleared, it's easily affected by electrolyte abnormalities, particularly low potassium. It interacts lots with multiple drugs, and it accumulates really quickly in renal impairment. So if we have a case where the drug dose is below the therapeutic window, you're going to have poor rate control in atrial fibrillation and no improvement in heart failure. Inside the window, you get improved cardiac contractility, slower AV conduction, which is good for atrial fibrillation rate control, and much more effective symptom management. But what happens above the window with toxicity is that you have a patient who has gastrointestinal symptoms with nausea, vomiting, anorexia. They can become confused and have fatigue. They can become bradycardic and develop atrioventricular blocks or ventricular ectopics. And so it's obviously that narrow window can become quite dangerous quite quickly. And finally, the last component of pharmacodynamics is the side effects of the drugs that we're giving. And there are two components of side effects, or two sort of categories of side effects. There's the on-target versus off-target side effects of drugs. So on-target side effects are those which are predictable, and they occur when the drug acts exactly where it was supposed to act, but the effect is either too strong or the target is present in multiple parts of the body. So you can have correct receptor, correct tissue, but an exaggerated or unwanted effect. And there's two mechanisms: excessive pharmacologic effect, so too much anticoagulation or too much sedation, or target receptor existing in other tissues. So for example, blocking beta-1 receptors in the heart can also affect beta-1 receptors in the kidney. The second category is off-target side effects, or type B, and these happen when a drug binds to the wrong receptor, activates or binds to the right receptor in unexpected tissue, or causes immune-mediated reactions. So it's the wrong receptor or the wrong tissue and an unintended effect. So, examples would be binding to an unintended receptor with poor selectivity, having an anaphylactic or allergic reaction, or there are some rare and non dose dependent responses. A good example would be an ACE inhibitor resulting in a cough or angioedema. And that's an off target reaction because there's an increase in bradykinin resulting in airway effects. So we've reached the most important part now, which is why pharmacokinetics and pharmacodynamics actually matter at the bedside, and why, as clinicians, it's important that we understand the concepts. Understanding pharmacokinetics and pharmacodynamics isn't just theory, it actually does change outcomes. Because when these processes shift, drugs can become subtherapeutic and not work when the patients need them. They can become toxic, causing harm, which can be life threatening, and they can become unpredictable, which makes clinical deterioration harder to recognise. And real cases often hinge on this. So the patient in renal failure who becomes drowsy and bradypneic after standard morphine dosing, the elderly patient who becomes delirious after a normal benzodiazepine dose, or the pregnant patient who needs a higher dose of antibiotics to reach therapeutic levels. And finally, the cirrhotic patient who bleeds after warfarin because metabolism and clotting factor synthesis are impaired. And these aren't rare events, these are everyday clinical scenarios. So if we have a slightly closer look, in renal failure, the kidneys can't clear drugs efficiently. So you're going to have reduced excretion, longer half-life. There's fluid shifts, which can alter the volume of distribution. And then there's increased sensitivity to CNS depressants and renally cleared drugs. And that's why morphine builds up in renal failure and can lead to respiratory depression even at normal doses. With liver failure, it slows metabolism and reduces protein production. And so there's reduced first pass metabolism and more free drug due to low albumin. And on top of that, there's impaired clotting factor production. With the elderly, aging affects absorption, distribution, metabolism, and excretion, so every component. There's more fat and less water, so drugs distribute differently. There's slower metabolism and reduced renal function. And that's why older patients often have a fall after antihypertensives or become delirious with opioids or sedatives. And they accumulate renally cleared drugs without anyone realizing. In pregnancy changes almost every system. You have increased blood volume with diluted drug levels, increased renal clearance, so drugs are cleared faster. You have altered liver metabolism. And then there's the potential issue of placental transfer and therefore fetal exposure. So things like antibiotics and anticonvulsants may require dose increases for the mother to stay therapeutic while still needing to be safe for the fetus. So that's pharmacokinetics and pharmacodynamics, how drugs move through the body and how they work once they get there. And understanding these principles is essential for safe prescribing, safe administering, and anticipating toxicity, and it will help you with assessing your patient properly. If you found this helpful, hit like and subscribe, and drop a comment for the next topic you want covered.